Good afternoon.
Good afternoon, Madam Chair.
Thank you, Senator Kramer. Today is Tuesday, March 24th. You have joined the Finance Committee. We're going to hear 14 House bills today. They are sponsor only. Madam Speaker, I want to apologize for making you wait, but most of my committee is over in your house presenting bills. So I have 4 of us. That's where we're going to start. So, Madam Speaker, would you like to come to the table and present House Bill 1364, please?
Yes, thank you. So good afternoon, Chair Vital and Vice Chair and members of the committee. It is great to see you. You know, this is quality, right? Who's here? There's a saying in Spanish that says that good perfume, expensive perfume, tasteful perfume comes in a small bottle, right? You don't need a lot of it. So thank you for having me. I am really grateful for presenting to you House Bill 1364. Good afternoon, Vice Chair. Good afternoon. House Bill 1364 is a simple yet important bill. They will use information found in mammograms to save lives. This bill will require notification to women in their mammogram results letter if breast arterial calcification is present in their mammogram. So I'm going to tell you what it is. Breast arterial calcification is caused by calcium deposits in the breast artery walls. It often resembles a railroad track pattern. This calcification is a solid, non-invasive marker for cardiovascular disease risk in women. Cardiovascular disease is the leading cause of death for women in the United States. Cardiovascular disease kills more women than all forms of cancer combined. Yet we're not exhausting every method of informing women about the risk. Cardiovascular disease is preventable through lifestyle and education. And when women are provided this information, it empowers them to be able to go to their doctor and explore it further. The notification approach taken in this bill has been proven to be effective. In 2013, most of you, if you were here, you voted on a bill that required mammogram result letters to include information about dense breast. Why was that important? Because dense breast is associated with a higher increase in cancer. And we went ahead and we passed that, and now when you get your notification letter, you see the language on dense breast. So what would this bill do? It would include language on this as well. It would include a simple language on breast artificial calcification and the association between having it and a high risk of cardiovascular disease. I personally met with all the stakeholders. That included Dr. Rachel Brand, who's the Chief Medical Officer of the Brand Foundation. I met with the radiologist and with the Maryland Department of Health. The bill that you have in front of you is a negotiated bill where all the parties are in support of it and are pleased with it. So the bill passed the House by a vote of 136 to 0, and I respectfully request your support. It will change lives, and there's no fiscal note, but you will save a life.
Thank you, Madam Speaker. Great bill. Do I have any questions for the Speaker? Seeing no questions, you did a very good job presenting. Thank you, Madam Speaker.
Thank you so much.
Thank you for visiting the Senate Finance Committee. I'm really appreciative that you're here. Thank you.
Well, I want to take a minute to say that I appreciate our partnership. We have served together. We came in together 20 years ago, and I have a lot of respect for you and our work together, and I'm going to miss you, but you're not going to get rid of me because we're going to stay in touch. And I want to thank you for your work. And the committee, thank you for your work and the bills you send us. I have an open door policy. You guys know how to reach me. And thank you for the support, okay?
Thank you, Madam Speaker.
You have a blessed day, everyone.
Thank you.
You're welcome.
Next, we'll have Chair Bagnall present House Bill 494, Health Insurance Primary Care Investment Targets, Reimbursement and Reporting. Thank you, Chair Bagnall.
I have Dr. Jacobs for questions.
Sure.
If you have any questions that require his expertise. Good afternoon, Madam Chair, Mr. Vice Chair, and members of the esteemed Senate Finance Committee. For the record, I'm Delegate Heather Bagnall, District 33C in Anne Arundel County, here in strong support of House Bill 494, Health Insurance Primary Care Investment Targets, Reimbursement and Reporting. You have my written testimony, so I will try to quickly summarize. We know well how essential primary care is to our care continuum. And advancing and expanding primary care is not only a priority of Maryland, but of the AHEAD model as a pillar in our total cost of care, and has continued to be a priority of the AHEAD model under the new agreement. Under the AHEAD agreement, CMS will hold Maryland accountable through performance requirements for meeting targets, which include primary care investment for all payers in the state. The targets are inclusive of expenditures for Medicare, Medicaid, commercial insurance, employer-sponsored insurance, and the state employee health plan. However, though CMS can hold the state accountable, currently there is no established mechanism for the state to hold payers accountable in turn for meeting the targets, which is why House Bill 494 is needed. House Bill 494 also grants the Maryland Insurance Administration enforcement authority to ensure entities meet primary care targets to be established in the bill. The MIA has established authority over and relationships with payers who have the capacity to make the greatest impact in primary care investment. Incorporating a description of their progress into the rate review process makes use of the MIA's existing resources and touch points with health plans in the state. Primary care is the only specialty where increased supply results in lower mortality and more equitable health outcomes, and thus should be considered a public good. House Bill 494 establishes the framework to incentivize reimbursement to healthcare providers in a manner that meets the annual primary care investment targets, establishes reporting requirements to demonstrate how they are investing in primary care, and requires carriers, when requesting a rate change or increase, demonstrate how they are meeting those primary care investment targets. There is no fiscal note, no opposition. It's patient-centered, outcomes-driven, and cost-effective policy, and for all these reasons, I ask for your favorable report on House Bill 494.
Dr. Jacobs? Senator Land?
Yeah, thank you, Madam Chair. I guess maybe this is for Dr. Jacobs. So I've been sitting on this primary care investment work group for probably 2 or 3 years now, stemming from legislation that we'd passed probably 2 or 3 years ago. Your predecessor was a part of it. You're a part of it now. And I've attended these meetings, and I think the last place that we left it with this primary care investment work group is that we haven't established targets yet. Is that correct? Because this bill looks like it's touching on driving the state towards meeting those primary care investment targets, which is great. Fully support that. We've had many discussions, many hours of discussions on this work group on, I guess, just definitions of like what's actually included in primary care. Can you just bring us up to speed on how that fits with what's contemplated in this bill?
Yeah, thanks so much for the question. And so for the primary care investment work group, and thank you for serving on it, we really appreciate it. We've had that methodologic approach. So in the past few years, we've made transparent where the different payers are in terms of their per patient per month primary care spend. And this year, after the executive order from the governor's office requiring us to establish those targets, we are developing that methodology that will be payer specific and based on the population that each payer has, and really based on also what it costs to take care of a primary care population in the ideal way, so a team-based way. And so we're on target and even maybe a little bit ahead of schedule with coming out with that methodology and those targets this year. And so by the end of the year, in accordance with the AHEAD agreement, we will have established those targets until 2030. And then what this legislation does is it fills that gap for accountability. So it allows us to hold the payers accountable because CMS can hold the state accountable now. And so unless there's a mechanism there, that's a gap.
So I guess back to the definitional piece, like what is primary care and how is that defined for purposes of this bill?
So this bill doesn't go into that kind of detail, but it refers to the targets that are established by the state. Within the primary care investment work group, we are using the AHEAD definition of primary care. So the AHEAD model has its primary care definition, And the state is in continued discussions with CMS about that definition as new codes come out that are relevant for primary care, for example.
So when you say that it's in discussion, does that mean that that definition of primary care could still change, or is that set for now for us to be able to move
It's
forward?
set for now, but every year CMS comes out with new codes. And so there needs to be some kind of process to update that, to keep pace with the times, basically.
So once the definition is set, is the intention then to come up with some percentage of the state's spend should be on primary care, or what are you envisioning as kind of the, it references obviously a lot of primary care investment targets, right? So is the target going to be a number that we're aiming for?
Yeah, it is. It's on a per patient per month basis. So as I mentioned before, we're trying to base it on what's that ideal team that we need to take care of Marylanders best. And so that's an interdisciplinary team that has all sorts of different providers, not exclusive to, but including primary care physicians, but it could also be NPs, PAs, care coordinators, and more. And so we're looking at the research. What does it actually take to take care of that population in terms of cost, and backing into, okay, so what is the per patient per month target that we should focus on for each payer? And so that's the methodology that we've been using collectively.
But this bill is mostly just information gathering towards the target, right? There is no stick to this approach. There's no enforcement mechanism. You will set a target as part of the work that MHCC does. The payers will report back to, it's either MHCC or an insurance commissioner, MIA here, on where they are in relation to your target. If they're not quite there, that's a subsequent issue to deal with later, I guess, right?
It's under MIA's discretion how to deal with that during rate review. So I can't comment on that precisely because, but if there's additional questions for MIA, we can take that back.
Okay. So the enforcement, if there's an enforcement piece, is really kind of under MIA's purview.
Correct. Yeah.
Okay.
But the triggering mechanism is that the attempt to change a rate or increase a rate, that they have to be able to define how they're meeting those investment targets. So that's
Right.
sort of the triggering mechanism, but the enforcement is under the jurisdiction of MIA.
Right. But the investment targets will be set by the work that Dr. Jacobs and MHCC does.
And the work group collectively, yeah.
Right.
Yeah.
The ones that we've had many hours of.
Yes, exactly.
Many hours.
Yeah.
Okay.
And thank you for that work.
Sure.
Thank you, Senator. I don't see any other questions. Thank you for your testimony.
Thank you very much.
I think the Secretary of Health is here. Mina Sessionami? There she is. I didn't see you back there, but you were next to my list. Thank you, Madam Secretary. We're going to present House Bill 272, Food Establishments Lavatory Requirement and On-Farm Food Service Facility License.
Great. Thank you very much, Chair Beidel, Vice Chair Hayes, and members of the committee. For the record, I'm Dr. Mina Seshmani, Secretary of Health for the state of Maryland. I am delighted to be here with Deputy Secretary Sullivan to discuss House Bill 272, Food Establishments Lavatory Requirement and On-Farm Food Service Facility License, which is ultimately designed to help Maryland farmers continue to provide the value they do for Marylanders in a way that is efficient and allows them to grow their operations. In light of the concerns that have been brought to our attention, it is clear that the farm community faces difficulties when acquiring food service licensure for wineries and farms. Currently, an on-farm food service facility license is limited to not more than 30 consecutive days with up to 2 renewals in 1 year, according to statute. However, agritourism facilities often operate differently. Weekends throughout the year, or they go for more than 3 months, and they may not be a full-time food service facility. So the Maryland Department of Health, in close collaboration with other agencies in the Moore-Miller administration, in particular, the Department of Agriculture, the Department of the Environment, along with the farm community and many others, proposed to change the on-farm food service facility license to a renewable one-year license, which more readily allows for multi-season food service. This provides a clear mechanism for farmers to provide food service on their farms in a variety of settings and operate more flexibly throughout the year without having to repeatedly apply for licenses to operate. Most importantly, this bill will provide the farming community with a predictable and logical roadmap to grow from small, limited food service operating only a few weeks of the year into a more sustained operation operating multiple seasons, and one that generates significant benefit to the farm. The aim is to do all this within reasonable boundaries that protect public health and ensure the farm continues its primary agricultural activity. The bill will rely on regulations that will be drafted in a transparent, open process involving public stakeholder input and public meetings, which will be discussed in greater detail by Deputy Secretary Sullivan. We respectfully request your favorable vote on this bill as amended. And I'd like to now turn it to Deputy Secretary Meg Sullivan for her remarks. Thank you.
Thank you, Secretary, and good afternoon, Chair Beidel, Vice Chair Hayes, and members of the committee. For the record, I am Dr. Meg Sullivan, Deputy Secretary for Public Health Services at the Maryland Department of Health. And thank you for the opportunity to be here today to talk with you in more detail about our vision for the regulatory process and resulting regulations for House Bill 272 as amended. You've already heard from the Secretary about the intent of this bill to address some of the challenges of expanding food service operations on farms in prior years. And to reiterate, our goal with this bill is to increase the clarity and flexibility of on-farm food licenses to better support farms and the communities they serve while continuing to ensure the appropriate public health protections are in place. I want to acknowledge that our three departments, Health, Environment, and Agriculture, have already done a significant amount of work with stakeholders to get us to this point, including the farm community, the Maryland Restaurant Association, the Maryland Association of County Health Officers, the Governor's Interagency Commission on Agriculture, and others to understand these challenges in anticipation of both the bill and regulations that would follow. And in particular, we want to acknowledge the important voice and role of local health departments who work with farms on licensing every day. We look forward to a regulatory process that involves a broad array of stakeholders, not only those I just mentioned, but also local governments and community partners, the business community, and more across the state. We are committing to you today that this process will be open and transparent and have public meetings for stakeholders to ensure that local communities and interests are taken into account. This bill purposely relies on the regulation process to determine many of the specifics, as this will allow the most involvement and ability for input from stakeholders, local governments, and sibling agencies. In order to ensure a smooth transition, the bill maintains the current on-farm license until the effective date of January 2027 to allow for regulation development process. In conclusion, while we have no illusions about the complexity of the task, we are committed to a process and a product that meets the needs of our state's farmers and the public who visit them to take advantage of the opportunities they offer. And with that, we respectfully request a favorable vote on this bill as amended.
Thank you. Do I have any questions for the Secretary or the Deputy Secretary? Senator Lamb.
Just one quick question. I'm just looking over the MACHO letter, and they had some suggested amendments. Were those incorporated into the House version before it came over?
Yes.
So they're already all addressed?
Yes.
Okay.
Yeah.
All right, thank you.
Thank you, Senator. I don't see any other questions. Thank you both for your testimony.
Thank you.
Next, we're going to have Delegate Shetty, House Bill 672, Public Health Maryland Pediatric Cancer Fund Entities for Eligible Grants.
Good afternoon. Really great to be here today. Thank you, Madam Chair, Mr. Vice Chair, and members of the committee. For the record, my name is Emily Shetty. Thank you so much for the opportunity to provide testimony in support of HB 672. This bill is Really, really simple. As you all know, this committee was integral in starting a pediatric cancer fund a few years ago. That fund had been appropriated $5 million as seed money to get it started. The $5 million wasn't spent. It was a target of fund shifting to the general fund. We kept restoring it, making sure that the $5 million stayed there. And last year, this committee, in partnership with the Health and Government Operations Committee on the House side, passed a bill to seat Pediatric Cancer Research Fund, almost like a set of commissioners that would help decide how those dollars would be spent. Thank you for your work on that. As part of that process, the individuals who were part of this work group discovered that the original fund was established to include for-profit entities unintentionally. And what that means from a procurement perspective is that an RFP has to be issued, which takes a long time to get these funds out the door. It was never the intention of the fund to be to have eligible entities that were for profit. It was meant for nonprofit pediatric cancer research hospitals primarily. And so what this bill does is it corrects the original fund to note that only nonprofit entities are eligible to apply, which means that the existing $5 million in the fund could actually be sent out as soon as possible, as soon as the RFAs are able to get drafted. This is not creating a need for additional funds this year. This just allows existing pot of money that's been sitting in our special fund for years to actually go towards its intended purpose. And right now, with NIH sort of the target of a lot of federal actions to lower the amount of cancer research actually happening in our state, these dollars really need to get out to continue the life-saving work that they were always intended to do. So with that, I am more than happy to take questions. This bill was amended to make it an emergency measure, and I think it might have passed unanimously in the House. It is a really important bill that will allow us to get funds out the door immediately. So thank you so much, committee, for allowing me to present, and I'm happy to take any questions.
Thank you very much, Delegate. It passed 135 to 1.
There you go.
There's this one negative vote I keep finding when I'm checking voting
We do
records.
have a member who is consistently a red vote on many things, and so I really appreciate the overwhelming support for this bill by my colleagues. Pardon me?
Thank you for your testimony. I don't see any questions. Thank you for bringing us the bill.
Thank you so much. Appreciate it, committee.
And we know who that colleague is.
Oh, okay. Well, I'm glad I didn't have to say any names. Thank you, committee.
Thank you. Is Delegate Queen here? She is. Delegate Queen, you want to come up? You have two bills. Let's start with House Bill 38, Financial Institutions Licensing of Affiliated Insurance Producer Mortgage Loan Originators Alterations.
Right. Thank you very much. Good afternoon, Chair Beidel and Vice Chair Hayes and members of the Finance Committee. It's great to see all of you. It's been a while. Okay, for the record, that's Delegate Pam Queen. I'm presenting HB 38, which is basically updating existing law to allow an insurance agent to be co-regulated as a mortgage loan originator under all the usual conditions, but the insurance company could contract with other banks of their choosing, as regulated by the Commissioner of Financial Regulation. So we're changing what's existing in law now, where the insurance agent and had to be co-regulated as an MLO if the insurance company owned the bank. And that is no longer the structure we see now in the marketplace. And so this law is just making the statute requirements updated because it's no longer reflecting what the market shows. And so this will give consumers more choice and access and it maintains that the same oversight that we have under the Commissioner of Financial Regulations still remains. HB 38 aligns Maryland with the practices that we see in 39 other states, which either have affirmative language or do not explicitly prohibit or limit insurance agents to be co-licensed as a MLO. And so this is a much needed change that we need. This bill passed out of the Economic Matters Committee 17-0 and the House of Delegates 136-0. And so we would like to see the same here. We ask for a favorable recommendation.
Gee, even the one delegate that usually votes no voted for this bill.
Did not even vote no for this one. I know. Isn't that great?
Do we have any questions for Delegate Queen on House Bill 38? Seeing no questions, Delegate Queen, let's go into House Bill 118, Maryland Money Transmission Act, definition of money transmitter, alteration.
Okay, again, Chair Bidle and Vice Chair Hayes and members of the Finance Committee, this bill should sound very familiar to many of you because you have a similar bill in the same posture that was sponsored by your chair. And so basically, this bill provides language to distinguish between payroll processors from money transmitters. And Maryland's only one of a handful of states that categorize payroll processors as money transmitters. There are 44 other states that make this distinction. This is important because small payroll processors, the cost of being compliant with being a money transmitter is often prohibitive and costly for them. And so we're really trying to make this a workable business arrangement that is, again, in compliance with most of the states that we have. This has been reviewed by the Office of Financial Regulations, and all of us are in agreement that this is a needed change. This bill also passed out of the Economic Matters Committee 17-0 and the House of Delegates 136-0. So we again are looking for a favorable recommendation for this bill.
Thank you, Delegate Queen. I think everybody remembers the bill, and so you have no questions. Thank you very much for your testimony.
Thank you.
Let's go to Delegate Ahrens, House Bill 535, Food Establishment Cottage Food Businesses Maximum Annual Revenue.
Good afternoon, Madam Chair Bidle and Vice Chair Hayes and members of the committee. For the record, Delegate Steve Ahrens here to present House Bill 535. It's a bill that increases the annual maximum revenue a cottage food business may generate from the sale of cottage food products. Although not to the scale of mass producers, cottage businesses still need robust facilities to operate food business effectively. Specifically, specialty equipment is not the only required to keep up with demand, but to bring safe and quality product to a local customer base. Cottage food business owners are using the best quality and many times Maryland sources of ingredients. The current income cap of $50,000 is not suitable to keep up with the increased product premiums. Increasing the annual revenue cap from $50,000 to $100,000 will keep cottage food business afloat, allowing them to continue offering quality products for the residents of the state. This bill was brought to me by a local constituent, and I was amazed after I got involved with the bill how many cottage industry we have in our own districts and what they're doing. And her circumstance was she had to actually support her family when her husband lost his job. And when she started going through it, she started finding out it was difficult under that 50,000 cap. And the important part of this bill, I think it will increase the number of these businesses in our counties and our state. The revenue generated will more than accommodate the fiscal note. We did have in the House bill, we had one unfavorable in the committee. I responded to that with the detailed explanation from the favorable and asked for any response back, and I did not receive any, and they did not oppose the bill in the Senate version.
Delegate, our record says House Committee 19-0 and House vote 136-0.
Yes, I was going to vote. I did vote for it. And I'm not the one you're referencing, by the way, but for the record.
Any questions for Delegate Aaron's, Senator Motz?
Since we were joking about the no votes, I just remember our side of ECM used to be called Death Row.
Yeah.
I'm so happy you've changed your ways.
They did move the seats around. So,
I don't see any questions. Thank you, Delegate.
thank you very much.
Delegate Allen, are you here? You're going to present House Bill 564, Pet Cremation and Burial Services Requirements, Services Consumer Protection Act.
All right. Thank you, Madam Chair, Mr. Vice Chair, esteemed members of the committee, Senator Jackson. My name is Nick Allen. See, it took a second. My name is Nick Allen. I'm here today to testify in support of my bill, House Bill 564, Pet Cremation and Burial Services Consumer Protection Act. The aim of this bill is rather simple. We're trying to establish additional consumer protections in the areas of pet cremation and burial services. And anyone who knows me will tell you how much I love animals, especially our pets. For many of us, our pets aren't just animals, they are members of our family. And when one of the members of our family passes, we grieve for them like we would for anyone else. And during this incredibly sad and vulnerable time, we also have a responsibility to ensure their remains are handled in a dignified, respectful way, again, just as we would for any other loved one. As we often turn to businesses who specialize in these services during those times. So I simply can't imagine losing a furry family member and then days or weeks later finding out that what I thought were their remains turned out to just be sand or building materials. And yet this happened just last year in Baltimore County to multiple families. They later found out that they found their pets' remains decomposing in the back of a car in a Baltimore City junkyard or on the side of the highway. I cannot imagine the devastation they must have felt and how violated they must still feel. The good news is the parties who perpetrated this fraud actually pled guilty the day before my House bill hearing on this. So this one in particular, while it's not a happy ending, there is some measure of justice. So this bill, again, seeks to make sure this doesn't happen to another Maryland family ever again. It mandates that all pet cremation services must provide a written description of their services to the owners of the deceased pet, as well as any veterinarian or other business owner who refers business to them for services, as well as the Maryland Department of Agriculture, who will be keeping the records here. The description must include a detailed explanation of those services, including whether the cremation is private, individual portioned, or communal. There are several other disclosure requirements in the bill as well. Additionally, the bill specifies that any storage of pet remains must be done in a dignified way. It puts again, but like a lot of other cremation services and funeral bills we've had, there's been some ambiguity about whether this falls under the Board of Morticians or the Office of Cemetery, I can't remember Cemetery Oversight, thank you. So this makes that clear, falls under the board. Additionally, there's record-keeping requirements for those cremation businesses, including a logbook that includes records going back at least 5 years, and they must ensure the security and confidentiality of those records. Finally, the bill includes enforcement provisions and allows the director of the board to refer violations to the Attorney General or the state's attorney of that county for criminal prosecution. I respectfully ask for a favorable report. Look forward to answering any questions. And if I may, Madam Chair, I just want to, because I think this might be my last time in your committee this year, I just want to thank you for everything you've done in your service over the years to the state of Maryland, to Anne Arundel County, and to your district, which was my district growing up and where my family still stays. So I want to thank you very much.
Thank you, Delegate. I appreciate that. Senator Washington, you have a question?
I do. Thank you. Thank you, Madam Chair. I really love this bill. It's a great bill.
Thank you.
Definitely thorough. Can you just remind us which other organizations would be responsible for oversight of these, and how many of these crematory or folk organizations or businesses that conduct this service? And do we know how many are in the state right now?
I don't have the exact number for you, Senator. I can get that to you. I know as the bill was drafted, it was originally under the Office of Cemetery Oversight, but the Health Committee amended it to put it under the Board of Morticians. Just for uniformity's sake.
And this is for oversight of that process.
Yes.
Got it.
And any violations, again, they'd be the body that refers violations to the Attorney General.
Got it. I know they do paw prints. Some of these places do paw prints too. How do we Is that part of it, or is it just the cremation part?
No, it's more for the burial services and the cremation services. Just to make sure people know what they're paying for, because again, some places will do individual cremation. They'll do kind of a communal one where they put a number of animals in at once and then kind of divide it up.
Yeah.
Or they partitioned is another one. Again, I was learning a lot about this business that I never thought I would learn about.
Yeah, they give you the option of doing individual ones, or they can do a group one too.
Right, group ones or ones where it's partitioned, like they put a bunch in at once, but they're separated.
Got it.
So there's different ways of doing it. So just so people know what they're paying for when they pay for it.
Got it. Thank you very much.
Of course.
Great bill.
Thank you.
Thank you. And we did, with the help of Delegate Banderi, to improve the oversight from the Board of Morticians. So I'm glad that it's under that board.
Absolutely.
Thank you, Delegate.
I think that's why the Health Committee moved it, was Delegate Bandari's bill.
Yep, thank you. Any other questions? I see no other questions. Thank you.
Thank you, Madam Chair.
I'm going to skip to Delegate Pruski. He was the first delegate I saw here today, so Delegate Pruski, would you like to come up and do, let's see what bill you're going to do for us. House Bill 1312, legal tender, species establishment.
Yes, thank you. Good afternoon, Madam Chair, Mr. Vice Chair, members of the committee. I'm here to present HB 1312, legal tender, species establishment. This bill is pretty simple. It allows our state to provide silver coins or gold coins or bullion as a recognizing form of legal tender. There are actually 11 states that have it. The closest is West Virginia. The bill would allow to use high purity gold or silver to pay for private debts, state level obligations like taxes or fees, considering though that both parties agreed to the transaction. It does not force anyone to accept gold or silver, but it officially recognizes in the state of Maryland as a valid legal tender. It's important, obviously, because economic stability, certainly some Marylanders are facing inflation. By treating metals as legal tender, the bill aims to encourage competition in the monetary system and to give citizens a way to store or spend their wealth. I would ask for a favorable report for 1312, and I wanted to highlight that the Office of Financial Regulations would come up specifically how this would work, and that is something in the bill in October of 2027 they'd have to come up with those regulations by, and that is it. Thank you.
Thank you, Delegate. Do I have any questions? I don't see any questions. Thank you, Delegate Pruski.
Thank you. Have a great day.
Is Delegate Hill here? Delegate Hill, would you like to do House Bill 599, Health Licensure of Hospitals Ownership Requirement?
Yes, I would. Thank you, and good afternoon, Madam Chair, Mr. Vice Chair, members of the Finance Committee. For the record, I'm Terry Hill, representing Legislative District 12A, and I'm here to proudly present House Bill 599, Licensure of Hospitals Ownership Requirements. This bill, which passed the House 96-47, would try and maintain hospitals in Maryland having a not-for-profit status by simply requiring that hospitals in Maryland cannot be sold to for-profit entities. At the time that we presented this bill in the House, the Maryland Hospital Association believed that all of its members were not-for-profits, and that's, I think, what most of us believe, particularly under our total cost of care model. Subsequent to the passage, however, we discovered that there is an entity that owns, I think it's Encompass, that owns 2 nursing home sites, one in Bowie and the other one in Salisbury. And so they've offered support for this bill with an amendment that would narrow this legislation to acute care hospitals only. I'd ask you to reject that amendment and instead accept the sponsor's amendment, which would carve out the Encompass, those 2 sites, so that they would be grandfathered in, but they would not be allowed to purchase other sites. As you all may know, generally speaking, for-profit hospitals have a different set of priorities than not-for-profits. They prioritize investor returns over patient care. They sometimes seem to charge more. They lack transparency, provide little, if any, charity care. And in fact, a study that was done right here in Maryland and reported out in 225 that focused on private equity penetration into private practices, but looked at healthcare more broadly, just reinforce that. We also have a number of cases, most recently nearby in Chester, Pennsylvania, where private equity acquired their major hospital system and then closed it down after stripping the wealth out of it, leaving a large community with no health care at all. And if an emergency arrived, the ambulance had to travel 20 to 40 minutes into Philadelphia to get care. We don't want to see that happening anywhere in Maryland, not in the rural areas, not in the western areas, not in the southern areas, and not in the central part of the state. So we think that this bill with the amendment will go a long way in helping to protect us from what can be the really negative aspects of for-profit hospitals. And with that, I'd urge a favorable report.
Thank you, Delegate. Did you get your amendment on the bill?
We had the amendment drawn up. I will double check with my staff. It should have
Because I
been.
don't see it on
Okay,
the
then we'll
record.
make sure that's taken care
Thank
of.
you. Senator Mouse?
Thank you, Madam Chair. And thank you for bringing the bill. It's an interesting area. And you were discussing the amendment. So Salisbury is in our district, District
Right.
37. And so I was trying to understand, you said the Encompass offered an amendment, but that amendment was not suitable, and that you preferred an amendment that prevented any growth. You wanted to limit it. You just wanted to grandfather those two facilities. Is that accurate?
Let me clarify. The Hospital Association has offered an amendment that would narrow the scope of this bill to acute care hospitals. So it would not simply grandfather the two Encompass sites that are for-profit. One is actually operated in along with but it would also allow other rehab hospitals, nursing home hospitals, all of those things to also be acquired. That is not the scope and purpose of the bill. The bill is designed to protect our communities, not just the acute care hospitals, but also the rehab hospitals as well. So Encompass, as you may know, is the single largest owner of rehab hospitals in America, and that's laudable, and I'm glad that they're here, but they also have been identified in multiple states as having practiced the exact types of practices we're trying to stop, where they leave communities abandoned. They are accused of selling the property after they receive it, decreasing the staff, which affects local workforce, and then leaving once the wealth of the value has been taken out of the facility. We don't want to see that happen. So,
And I guess is the theory that the nonprofit hospitals are going to fill the vacuum for these acute hospitals?
well, again, in Maryland, other than that example, all of our hospitals are not-for-profit. So it would really be maintaining the current
The
status.
acute care rehab is a big deal.
It is a big
So
deal.
my question is specifically, I mean, the future, looking forward, is the thought then that the nonprofits are then going to fill the void, because there's a huge void. So most of our constituents go to Delaware for rehab hospitals because there's nothing available. And so we have one that's operating. Proposal is as well, because it's for-profit, we need to implement this nonprofit requirement. And so my question is the theory that the nonprofit hospitals are then going to go into this and then fill the
Right.
void, because there's a huge void?
So I would say this, Senator Miles, again, at the time the bill was introduced and at the initial presentation in the House, we didn't think there were any for-profits in here. Okay, so the expectation was that we would continue to do all the things that we're trying to do in multiple areas, as you know, this committee and across the street in the Health Committee, to encourage broader expansion in all areas, including providers and all of that. So yes, we will be leaning on the not-for-profit model that has served us not perfectly but well up until now for our future needs as well.
Okay. And so if the acute, my phone's listening. Sorry about that. So if the acute if the for-profit entities in the acute rehabilitation hospital business.
That's the non-acute setting. The acute hospitals are, you know, your University of Maryland, your MedStars, they're the ones that take care of what we think of as acute care, not emergency, but can be emergency. The non-acute hospitals are what encompasses, those are the rehab hospitals.
Then, yeah, the rehab hospitals. So for the for-profit rehab hospitals, if they say, this nonprofit requirement is not workable for them, what is the thought on how to address the conflict?
Right.
What is your thought on how to address the
My
conflict?
thought is that we would continue to do the work that we've been doing to take our current model where we don't have, with this one exception, the for-profits, to continue to encourage and lean in on making not-for-profits and making the quality that's delivered in the nursing homes and in the rehab facilities better, and to support them in their needs for staffing and all the other things that they need to continue to do well.
Yeah, I'm sorry I didn't prepare for this because it's been busy. We just did crossover.
You've been busy. What's going on?
Yeah, it's been crazy. And you've been crazy. The house has been crazy. But, and I don't have any studies, but I know there's got to be a shortfall in these rehab hospitals.
Let me try and answer your question.
Mm-hmm.
I think what you're asking is, if we don't allow for-profits, how are we going to fill the needs for our rehab hospitals?
No, my question is are we filling the need right now with what's available?
I think we have issues now. I just don't think that for-profits are the answer. And I think if we go to for-profits for the answers, we're going to find ourselves down the road with the same problems and with our pants down and our butts exposed.
Okay. With regards to the proposal of the for-profits, I guess the issue with that is that they would not be limited in growth, so they would be able to grow under the amendment that they proposed.
The Hospital Association Amendment would allow them, my understanding is that they are interested in acquiring other sites. And I think it is reasonable and fair to say that we're not going to introduce legislation that's going to prevent you from doing what you're doing. But if we think that for-profit penetration into our hospitals is problematic, then we wouldn't say, but because you've been here, you can continue to grow.
And there's got to be a gray area.
Let me just finish. And again, I think that if for-profits, if Maryland were the environment where they want it to be, we would have seen a lot more of them. We know from the study that was put up by MHCC that there's significant penetration of for-profits into the physician practices, okay? And then of the hospitals around the country, it's primarily rehab hospitals that have it. And again, this is a trend that I'm saying we don't want to see. The for-profits have not been what's saving Maryland now. I don't think we should be looking to them to be our savior. And what I'm suggesting is, rather than outright ban them as the legislation would have done as introduced, let's recognize that we have one entity here at 2 sites, and let's make sure that they're allowed to stay.
I understand that. You've been very clear. I'm concerned about the access to these facilities, I really don't have another question. I just wanted to get a better feeling for your thoughts about their amendment and those comments that you made. And I just to share, I just know this is a huge issue for access to care, especially in our district. I can't speak for the whole state, but I appreciate you answering my question.
And let me just say, I appreciate that. Be happy to talk to you about offline, but I will tell you about Chester, Pennsylvania, because that's where my family is from, and it was devastating. And they took in the for-profit. They thought they were the great savior, and they weren't. And they're much more devastated now than they were before.
Yeah.
And the state is now having to figure out how to make sure and how to move pieces around and get someone to take over. We've seen that here with even our hospital, whether it was Greater Laurel Hospital closure, the hospital closures up in Hartford County. Our state has had to step in, even without a for-profit models, when hospitals close down. I don't think we want to set ourselves up knowing that how the trends are looking for that being even worse.
Yeah, I can appreciate that. my experience on the shore is very different in that there's nothing to close down. We're going to Delaware, we're going other places, or we're not going anywhere. And my father was a dentist, and so very familiar with the consumer private dentist, and I'm very well versed on the for-profit role and the problems with that. But I'd like to talk.
So maybe we can
could
talk
some
about
more.
some solutions that would actually be beneficial in the long term.
Sure.
Great, thank you.
Thank you. There's another question, Senator Washington.
Thank you, Madam Chair. Thank you, Delegate Hill, for this bill. Just some clarifying questions. Does this bill, as amended, ban the hospital, acute care hospital in Bowie?
No,
Do you accept the amendments from MHA?
no, we've offered the alternative amendment because their amendment would allow for this one entity to continue to expand throughout the state.
And the goal is to not expand throughout the state?
The goal was to not have any for-profits,
Yeah,
but since we have one, the goal is to not stop them from doing what they're doing.
got it. Is there a problem with them right now that we don't like?
I'm not aware of a problem here in Maryland, but I became aware that they were here 2 weeks ago, have not done an investigation. Again, the Hospital Association, at the time we introduced the bill, thought, and you can look at their House testimony, and everyone's saying, not a problem for us to do this. We don't have for-profits in Maryland. Maryland's not going to see this as a problem. And then it was like, oh.
So we
missed, right.
could potentially see them grow more.
We
without
could
this
see the
bill.
problem, yes.
Got
So
it.
this is really proactive.
Yeah. So there's,
We're reading the tea leaves. We're seeing what's happening in the rest of the country. We feel very fortunate that 99% of ownership here in Maryland is under a not-for-profit model, and we're saying let's make sure that as we're dealing with all the other things we have to deal with, we don't add another problem.
so we have your amendment and MHA amendment.
And it's one or the other. They're not. They're pretty much mutually exclusive.
Got it. Fair enough. Thank you very much.
All right. Thank you.
Thank you, Senator. I don't see any other questions. Thank you, Delegate, for that bill. Your next bill is House Bill 1263, Public Health Work Group on Post-Operative Cosmetic Care.
This is sponsor only? Okay.
Sponsor only.
All right, thank you. All right, thank you very much. House Bill 1263, and again, for the record again, Delegate Terry Hill, Howard County, District 12. So, landscape of cosmetic and body-altering procedures, which includes all kinds of energy-based devices and technology, is a rapidly growing area. It outpaces the regulatory framework that we currently have in the state. Most of us think of cosmetic care as cosmetic surgery, and maybe some injections and fillers and some devices that we think about physicians using, maybe med spas, which might be run by nurse practitioners, maybe some estheticians. But the whole field also includes what happens when you've had a procedure and you need some kind of aftercare. That might include massage therapy, lymphatic therapy, might at times also include things like wound care. But what we're realizing is that that's an unregulated space. And there was a bill introduced by Delegate Martinez a couple of years ago that talked about people who were unlicensed, who had sort of recognized this problem and wanted to convene a group to figure out where the territories were. And I thought that was the right idea and the wrong bill because, frankly, the people who should be looking at this are the physicians, the nurses, the massage therapists, the chiropractors, the licensed people, the nurses who actually care for people from prior to procedures to after procedures. But we don't have any idea who else is laying hands in this area because it's unregulated. So the work group that would be established would essentially be those entities to take a look at who are the folks that are advertising that they can provide post-surgical care. And this care is not falling under the surgeon or any other physician's direction. Who are they and what are the procedures they're coming with? Again, as some of you may know, seems like every year And, there's a new device that's designed to make you smaller, make you thinner, make you taller, stretch you out, heat you up, tighten your skin, and whatever. These are often unregulated devices. And if the Board of Physicians is saying they don't have authority over it, and the Board of Nursing has no authority over it, the Cosmetology Board has no authority over it, the Massage Board has no authority over it, Acupuncture Board has no authority over it, then who the heck has authority over it, and who's protecting our constituents? So that's what this group is being convened to figure out. What is the depth and breadth? What is the nature? And who are the right boards to do this? Who are the right people to give advice? And if they don't exist, what do we need to form to make sure that we can catch up with the technology and then, for the sake of our constituents, stay ahead of it? And with that, I would urge a favorable report.
So, Delegate Hill, I want to know about the one that makes you taller.
Well, I know how to do that surgically. We can cut your legs, put little pins in, and then stretch them about a centimeter a day, and then the bone will grow back through. You will be taller.
Thank you.
I've done that with fingers.
Senator Mounts.
Thank you, Madam Chair. This is interesting. So the cosmetic care, is there like a list of what cosmetic care is, or is that what the work group's going to sort of come?
Well, so we actually have a fair amount of statutory language that talks about plastic surgery and what that means and what the delegation of a plastic surgery is to a nurse or to someone else. So we've done a lot around that. But these areas have come up beyond that, and they're sort of beyond medicine generally.
So the work group would probably try to define that. And my next question is med spas. Med spas are very popular. They're very busy, and they're growing. I mean, they are very active. So how would med spas be covered under this work group?
I think we'd be looking at what are the things that med spas are being, where there's appropriate oversight, and what they're doing, and who are the licensed practitioners who are in there, and what, if any, are the unlicensed things that are being done.
And are pharmacies included in the work group?
They have not been.
Because the med spas I'm aware of in my district are usually pretty close to a pharmacy, and they're in a medical. Usually they're mixed in with medical offices.
I used to have a med spa in my practice.
Oh, yeah. Okay. Well, yeah. And it always gave the appearance that somehow that was involved or closely related. I'm not for certain, but I didn't know if.
They're not included in the group.
Okay.
But would have no objection if there are other groups that, feel like we had the acupuncturists were added because they were at the bill hearing for another bill and came up to me afterward and said, we think we have something to offer to this group.
Do the med spas have a representative? Are they going to be involved in that work group? Do they have a representative?
I don't think they have a stated representative, but certainly open to that amendment. I really do think that this is a conversation that is larger than any one group sees, and it is the patients and, frankly, some practitioners, some unlicensed, some licensed, who are saying, I have seen these problems walk in that other people have been causing. And so we think this is it deserves a look.
I'm not proposing. That was just a question.
Throw the amendment on there.
Yeah. Thank you.
Because it's out of the House. It's in the Senate now. It's on you guys.
That's right.
Anything you can do to make it better is appreciated.
Thank you.
Thank you.
I don't know if I would tempt him with that, but thank you, Delegate. I don't see any other questions. Thank you for the bills.
Thank you.
Next, we have Delegate Bandari, Home Builders Open House Sales Representative Disclosure Requirements. It's House Bill 850.
Good afternoon, Madam Chair, Mr. Vice Chair Hayes, and Senator Jackson. You're very popular today. For the record, this is Delegate Bandari, representing District 8, House Bill 850. It's a very simple bill. It requires home builder, when holding a property open to the public, to display a notice that the sales representative represents the builder's interest and informs prospective buyers of their right to independent representations. And today, when a licensed real estate agent hosts an open house in our state, they already requires a clear posted sign stating that the agent represents the seller and that buyers have the right to their own representation. However, that same level of clarity does not exist when a consumer walks into a new home model or builder open house. This bill fixes that problem, and it does not regulate prices, contracts, or compensation. It does not change who represents whom. It simply ensures that buyers are clearly informed at the beginning of the process about the roles of the sales representative they are speaking with. Originally, MBIA had a concern about what does this bill do, and I had a long conversation with them, and they were neutral. They are fine with this bill, and it passed Economic Matters unanimously and passed House unanimously. And there is no opposition. And I would love to request, I will definitely, a favorable report on this House bill. And I would also thank Madam Chair for everything you did. And I had a wonderful time working with you, and great bill like ER wait time bill to State Board of Mortician and Funeral. And we'll miss your leadership. And thank you for everything you have done.
Thank you, Delegate. You've been great to work with also. Do I have any questions on House Bill 850? You're getting off easy, Delegate. No questions. Thank you.
Thank you.
Next, we'll have House Bill 882, Delegate Kaufman. Delegate Kaufman's going to do House Bill 882, Consumer Health Information Termination Date and Mandatory Funding for the state's Consumer Health Information Hub, repeal. Thank you, Delegate.
Thank you, Chair Beidel, and I just want to join the chorus in thanking you for your decades of service to the people of District 32 in the state of Maryland. It won't be here with you. It won't be the same without you. And a big hello to my dear friend, Senator Kramer. Good afternoon, Chair Beidel, Vice Chair Hayes, and members of the committee. For the record, my name is Delegate Aaron Kaufman, and I respectfully request a favorable report on HB 882, Consumer Health Termination Date and Mandatory Funding for the state's Consumer Health Information Hub repeal, because it expires on June the 30th if nothing is done. Maryland has made nation-leading investments in clear health communications. In 2022, Madam Speaker Pena Melnick established the Maryland Consumer Health Information Hub through HB 1082 to advance health literacy, plain language, and language access statewide. The hub, housed at the University of Maryland's Hurwitz Center for Health Literacy, ensures people can find and understand health information. In just 2.5 years, the hub has strengthened relationships with state agencies, local health departments, community organizations across Maryland. It has developed practical tools such as the Maryland Plain Language Checklist, web content review tools, criteria for grants and media campaigns, and a plain language and language access planning guide. And I think this is all very important, Madam Chair, because I like to think I'm reasonably a smart person, but I've had a lot of medical experiences in my life, and sometimes I just can't understand the medical parlance. So that's why plain language is so important. It also created the Maryland Health Literacy Organizational SEAL program regarding agencies that institutionalize clear communication standards. The hub supports the public health workforce directly. It provides health literacy training for community health workers to reduce misinformation and distrust, address cultural and linguistic barriers, and help residents navigate complex health systems. It offers webinars, convenings, and peer collaboration spaces so agencies can share best practices and modernize communication tools. But don't take my word for it. As documented in the 2025 Maryland Legislative Report submitted by the Hub, the impact of the work is measurable, statewide. Since July 2024 alone, the Hub has engaged more than 116 Maryland agencies and organizations and participated in over 160 community meetings and outreach events across the state. 90 webinar participants demonstrated statistically significant increases in knowledge of health literacy and plain language practices, with average scores rising from 2.6 to 3.6 on a 5-point scale. 74 professionals representing all 24 jurisdictions attended statewide convenings, reporting increased confidence in implementing Maryland's plain language standards. Additionally, 83 community health workers completed specialized communication training to better support residents navigating complex health systems. The data reflects concrete, measurable improvement in Maryland's public health communication infrastructure. State and local partners have emphasized that implementing the plain language as a routine way of operating requires leadership, support, and coordination and sustained infrastructure. This bill ensures that the Hub remains in our state beyond its current sunset date in June, allowing Maryland to continue institutionalizing clear communication statewide. It also removes the mandatory appropriation requirement, providing fiscal flexibility while preserving the annual report and oversight. So therefore, I ask for a favorable report because this legislation does not expand regulatory authority. It sustains a communication infrastructure that improves transparency, strengthens public trust, supports language access, and advances Maryland's broader public health goals. So for this reason, I respectfully request a favorable report on HB 882.
Thank you, Delegate Kaufman. Do you have any questions for the delegate? Senator Kramer.
Thank you, Madam Chair. I just wanted to take a moment to share the love and tell my dear friend, Delegate Kaufman, what a pleasure it is to have him here in committee.
Thank you, Senator. It's always an honor to carry on the work of Speaker Peña-Melnyk, so I'm glad that in terms of the Hub, she passed the baton to me. Thank you very much. Thank you, Senator Hayes.
Okay, that's all good. I don't see any other questions, Delegate. Thank you for being here.
See you guys around.
All right.
Thank you for your patience.
Thank you, Madam Chair. And I have Dr. Brookmeyer here with me just to answer questions if there are any technical questions. Thank you so much. Thank you, Chair Beidel and Vice Chair Hayes and members of the Finance Committee. Bill's concept's pretty simple. Suicide impacts all of our Maryland jurisdictions. It is a public health issue that we as a state have dedicated legislative, executive, and administrative resources towards intervening and mitigating. Building off of the existing public health infrastructure for a local fatality review, House Bill 1012 authorizes jurisdictions, health authorities to create local suicide fatality review teams similar to what we already do with our opioid fatality review team. While there is a statewide suicide fatality review team that was created by the General Assembly in 2022, it really takes a 10,000-foot view of the issue. It does not review every single suicide fatality and does not provide recommendations that are tailored to the jurisdiction where the fatality occurred. Though it is mandated to report annually to the General Assembly, to date, Our office has gotten one total report, and that makes any substantial policy recommendations. My bill before you today would enable local health authorities to create their own suicide fatality review teams, to provide in-depth analysis and timely recommendation policy changes that are grounded in the local context of each death. We have worked with the Department of Health to craft legislation that ensures flexibility to ensure each locality can implement the teams in a way that is workable with them, while maintaining strict confidentiality for victims, which were adopted by the House and sent to the Senate 128-8. It is my hope that this legislation will allow jurisdictions the ability to develop responsive strategies for mitigating suicide fatalities in their respective territories, leading to more effective local interventions at a time where mental health crises and suicidality are an all too common occurrence in communities across our state. To give jurisdictions more tools to review, address, and intervene in suicide fatalities, I respectfully request and urge the committee to give House Bill 1012 a favorable report. Thank you, Madam Chair.
Thank you, Delegate Fair. I don't see any questions. Oh, I do. Senator Lamb.
Madam Chair, thank you, Delegate, and good to see you, Dr. Brookmeyer. Just a question, I guess a baseline question. This allows local jurisdictions to set one up. Are there local jurisdictions that already have established local suicide fatality review teams?
Dr. Brookmeyer, who's the Public Health Officer for Frederick County Health Department.
There aren't currently because of the concerns about the sharing the data. It's both the data that's shared needs the protections, needs the legal protections. The people who share the data and the people who hear the data, we need protections against third-party forced disclosure. So this is modeled after the local drug fatality overdose review teams, which had passed in 2014, and that was modeled on the child fatality review teams. And what I can say is for the overdose fatality review teams, what we have done locally, again, looking at the context of what were the potential system interception points that if we work on together, and that we have worked on together, to prevent future such deaths. And for the overdoses, that's one of the major contributors locally in the system that we have woven together to try to prevent as many overdose deaths. Similarly for child fatality, although fortunately we haven't had as many, and we are hoping that for the suicide fatality, if we are able to have those legal protections to be able to discuss the cases, then those around the table can identify potential system intervention points so that we can prevent future suicide fatalities. Thank you.
So your sense is that there are local jurisdictions who are interested, have just been kind of held back because there aren't the adequate protections in place?
Yes, there are at least 3 others.
Okay. And then there's enough flexibility in, it enumerates some of the members that could be on it, but these are, I guess you have to draw from these, but you have flexibility to do what you need to do when it comes to these members. The chair is not always a health officer, I guess, right? So the chair would be designated by whoever, by the review team themselves.
Yeah, so page 3, line 17 really opens up that opportunity, and I'll just mention that in my full-time job as the executive director of a nonprofit, I serve on the Child Fatality Review Board to provide those intersectional components about why these things are happening.
Okay, all right, sounds good, thank you.
Thank you.
I don't see any other questions. Delegate Fair, thank you for the bill.
Thank you, Madam Chair. Thank you, everyone.
And our last delegate for the day is Delegate Solomon, House Bill 1068. Somebody has to be last delegate, I'm sorry.
Certainly not least.
This is House Bill 1068, Health Insurance Special Enrollment Period for newly hired employees of small business.
Thank you, Madam Chair. And I've got
delegate. Thank you.
Member from Joanna here from the Maryland Health Benefits Exchange for questions. And it was lovely to spend the afternoon. I learned how you grow somebody if you're a plastic surgeon. I don't know that I really wanted to know that, but appreciate that from Dr. Hill. Good afternoon, Madam Chair, Mr. Vice Chair, members of the committee, dear friend Senator Kramer. For the record, Delegate Jared Solomon here from District 18 to present House Bill 1068. Good to see a lot of friends here. And Madam Chair, I will just say as well, think of us fondly next year when you're enjoying the sunshine and the warm weather, and I will miss our collaboration, particularly on Mark Rail. I was just going to say, exactly. So I am here to present a bill that is actually fairly straightforward, and was really honored to have the Maryland Health Benefits Exchange approach me in the late fall to bring this. And what this bill would do is create essentially a special enrollment period for newly hired employees of small businesses, so businesses with 50 employees or less, who do not offer employer-based coverage. So I worked really collaboratively with the Health Benefits Exchange on a bill that the General Assembly passed last year to try to incentivize and increase uptake and do direct outreach to childcare providers, which I know is really important to many of us. And so out of that work came, hey, would you like to do this? And this bill actually came out of a recommendation from a 2023 work group on how to increase access and uptake of coverage through the exchange for employer-based, small business, workers of small businesses, and was included in a 2023 bill. Unfortunately, that bill had a $5 million fiscal note because it included a $5 million access fund. And so the really good policy that was in there got sort of put to the wayside because of the fiscal situation, not a commentary on the policy. There were a couple of changes that we made to the bill as it came out of the House. The Health Committee worked really collaboratively with the Benefits Exchange and took some of the recommendations. There is one unfavorable testimony in here from the insurers. Kind of unsurprising. I don't think they like special enrollment periods very much. But the amendments in the final version of the bill that came out of the House created a 30-hour-a-week threshold. They also created the requirement of a compliance form that is designed by the Benefits Exchange and the Insurance Commissioner, that a business just has to certify the start date of the individual and that they are actually working 30 hours a week. And then we forgot to put in a definition of a dependent in the original drafted bill. And so we added that in here. I think just the one statistic that I want to offer to you that I think is really important, when you look at the percentage of coverage that is offered by size of employer, when you start with an employer that has more than 50 employees, 96% of employers in Maryland offer health coverage. When you get to employers that have 10 or fewer employees, it's 35%. So the drop-off is pretty dramatic, and I think less sort of on the healthcare side. What was really enticing to me about this piece of legislation and why I was really happy to put it forward is it's just giving another tool in the toolbox to level the playing field for small businesses who are trying to hire folks. And at a time where we are trying to do everything we can to strengthen small business owners, and we are trying to do it in a way that doesn't cost a whole lot of money, being able to provide some sort of equal benefit for somebody who might be weighing, I could go work for this big company that maybe I don't like the job as much, but they provide employer-based care, or I could go work for the small business owner and not have to wait another 6 or 7 months for an open enrollment period. This is just another way to level that playing field. We don't think it's going to affect a whole lot of people, like maybe a few thousand a year. This is a fairly small population. It would essentially be somebody that does not have health coverage in any form or fashion, and then gets hired by a small business that does not offer employer-based coverage. They would then have access to this special enrollment period, as opposed to having to wait until the next open enrollment period would open up. This bill actually got amended with Republican co-sponsors out of the Health Committee, which was really gratifying, and passed, I think, 119 to 15 out of the House. So with that, would ask for a favorable report, and happy to take questions.
So Delegate, you're right. The only unfavorable testimony is from various insurers. Did you think you addressed their concerns with the amendments?
I think we did, yeah. Delegate Cullison in particular was the one that spearheaded this, and I think their biggest pushback was sort of on, well, we're worried that there may be somebody that tries to figure out how to game the system. As Joanna can share, there is annual reviews done and audits. There hasn't really been any instances of that. I think the form and the process that has been put in this bill is pretty much standard for all the special enrollment periods that are already existing in statute. And again, we think this is a pretty small subsection of people that this will qualify for, and the amount of hoops you would have to jump through to be able to qualify for it seems pretty nominal. That if somebody truly wanted to try to game the system, there's probably easier ways for them to do it than to qualify. Go find a small business, get employed, work for a short period of time, get your employer to sign off on a form, qualify for health insurance, and then somehow disappear.
Thank you. Do I have any other questions for the delegate? No? Thank you very much for the bill.
Thank you.
That ends the hearings for today. Thank you all very much. Just